Hey everyone, this is Tim, your lecture instructor for the Paramedic 2 RN program. And today's voiceover is going to be on autoimmune disorders. There's not a lot of them, just a few. I think for this chapter or the reading that you're doing, I think it's more of what you're going to assess. Looking for signs and symptoms, probably more of a history, a little bit of blood work, what interventions you'll do. A lot of times autoimmune disorders, there's not a whole lot you can do other than really treat the symptoms. You can put them on immunosuppressant therapy to try to help, keep their body from attacking itself, and pretty much, making sure that the interventions are going to work. So pretty simple, pretty straightforward. So for rheumatic disorders, we have systemic lupus erythemus, and we also have RA, which is rheumatoid arthritis. Both are autoimmune, they're degenerative, they're inflammatory, and they're also systemic. They also both affect the joints, muscles, and tissues. So for RA, or rheumatoid arthritis, is the destruction of synovial fluid, breakdown of collagen, forming of pannus, and destroying of cartilage and eroding bone. So for the most part, rheumatoid arthritis, the body's actually attacking itself. It's destroying the synovial fluid and the collagen, which is the cushion between the bones and the joints. And because of that, it starts to erode the bone itself. For an assessment and diagnosis, you're going to assess stiffness, tenderness, swelling, and temperature changes. When I think of rheumatoid arthritis, I always remember the older ladies that have the hands that seem to be not so far as disfigured, but just have that shift in an angle. To diagnose RA, you're going to have to do blood work for RA factor. You're going to look for antibodies to cyclic citrullinated peptide. You're going to also do your erythrocyte sedimentation rate, C-reactive protein, synovial fluid to test it to make sure that it's not milky or cloudy or dark yellow. And you also do x-rays, which is the erosion and the narrowing of the joint spaces. So again, for the most part, you're really just assessing, and then you also do some diagnostic studies, especially the blood work. I think from what I understand, there's several markers that they have to meet in order to be RA positive. For medical management, it's decrease joint pain, decrease swelling, try to achieve remission and minimize joint deformity and minimize disability. Again, for the most part, you're really treating symptoms, which is going to be more inflammation and pain. And again, that's what you can do. You try to do your best. I have friends who have RA and they're on long-term chronic pain medication, and it seems to do well. And if you actually find yourself a really good doctor, they kind of start you low on the pain medication dosage, and then as things progress, you actually will increase the amount of pain medication you're taking. And the reason why is this is a lifelong disease. So if you're in your 20s or 30s and you're taking high doses of narcotics, by the time you're 60, 70, 80 years old, nothing's really going to touch it. So again, I think that from what I've been told from friends who have RA, the biggest blessing is the fact that they found the right doctor who is able to really care for their symptoms and do what they can to make sure that this doesn't progress any faster than it has to, or try to slow it down as much as possible. For nursing management, it's going to be nutritional therapy. You're going to teach them how to eat right, eat well, and as healthy as possible. At some point, I don't see it listed here. What I would probably do is make sure that they lose the weight. That's going to eliminate some of the stress on their bones, and the weight itself is going to be the heaviness itself is what really starts to really bother them and increase the pain. Sleep disturbances, because the fact that they don't sleep very well because of the pain. So if you can really control the pain and actually have them sleep better, people who sleep well tend to heal better and feel more relaxed and restful, which leads to fatigue if they don't get it. Altered mood, I think it's more of just the fact that the lack of sleep and you're in pain and you're grumpy and just I think that again, if you can control the symptoms, the psychological aspect of RA probably not necessarily eliminated, but just better. You're going to encourage them to do more exercises, or at least what they can do. The limited mobility is because of the disease itself, but if they don't do much, then they eventually will break down faster, and you're not really keeping what you do have actually working as the best it can. Complications for medications, a lot of the medications to slow the disease process down are immunosuppressive, and because of that, they tend to get sicker, or they have to be able to do what they can to not get sick. And also self-care. I think you try to promote within the patient to do what they can, and if they are limited, helping them out is fine, and support and stuff. But at some point, if they're not doing anything for themselves, they really are just breaking down faster, and they're not really going to be able to regain that back. Systemic lupus erythemus. It's an autoimmune disorder affecting every organ in the body. It affects more women than men, affects more African Americans than Caucasians. It's usually found earlier in life rather than later. The theory is that lupus is brought on by genetics, immunological problems, hormonal and environment, such as the sun, virus, trees, diet, and prescribed drugs. So it wasn't just initially an autoimmune, but something has actually triggered it on the outside. Clinical manifestations are butterfly-shaped erythemus rash. So as you can see here, you can actually see the rash going on bilaterally around her cheeks and her eyes. The criteria for classifying lupus is on page 1071, chapter 39-5. Criteria for classifying, and it basically has more of an assessment than anything else. Major areas that are affected is for cardiac, it's the pericarditis. It can also cause hypertension and cardiac dysrhythmias. For renal, it's nephritis, increases creatinine levels, and you need a UA in order to actually diagnose and to find out where the damage or the extent of what the damage is done. Central nervous system could be psychosis, stroke, or cognitive impairment. Medical management. So treat the symptoms and fix the organs. So basically, again, you're really treating symptoms, and you're going to pretty much do lab work to determine if things are actually affecting the organs themselves. Pharmacological management is pain medication. You can do corticosteroids and anti-malarial and immunosuppressants. Just like with RA, you're really doing immunosuppressive drugs in order to either slow it down or keep your body from completely breaking down the body. The corticosteroids is more for anti-inflammatory, and the pain meds are just to actually keep the patient more comfortable. For nursing care, nursing diagnosis could be fatigue, impaired skin, body image disturbance based on the butterfly rash, deficient knowledge for self-management decisions. So again, for both autoimmune disease, it's more of education, teaching them what they can, what they should be doing in order to actually slow the disease down, or at least to sustain as much of a independent life as they possibly can. And again, to actually treat the symptoms. 8 minutes, pretty quick, pretty simple. Just read through the pages. Again, you're really just kind of, what is the disease? What is your assessment of the disease itself? What interventions are you going to do, and what are you expecting to actually happen? If you have any questions, bring them to class.